Okay, should we start? हाँ एक बार कॉल कर दे. Hello. Okay. So we'll start. I think you can see the slide, right?
Yes, sir.
Okay. Okay. So today's meeting is a general meeting where we'll be discussing it. This is not like only I'll be speaking because that's why I asked like any of you have some experiences or have seen something or done something in the OPD or in general clinic which might have caused some issues. So it is a method to share our experiences. But over a period of last almost say 12 to 15 years when I'm involved in hospital management, these are few of the things which I have noticed and which have usually causes issues with the patient management. Okay. So to begin with, what is the difference between, there are different similar names which we use like mistakes, errors, fault, and then blunder, error, something was wrong, something like that. So what we mean by blunder is that something which is stupid or careless mistake, which sometimes we ourselves either repent or sometimes we still do not accept it. And that's why we keep on doing the same mistake again and again, making it a blunder. While errors are basically because of lack of knowledge. So we call it error of, maybe it's a wrong technique which was chosen or wrong treatment was chosen or something like that. That is because of lack of knowledge. Well, mistakes are mainly accidental, where you are not aware that you are making some issue. So blunder is something where somewhere down the line, you know that this is something which is not to be done, or you are just casual about that thing, and that causes issue. Okay, so these are few of the things which I jotted down, and so I will discuss it one by one. Some things you may feel little hard, but some of these mistakes have been done by even me during the initial years, even later. And we have to understand that we should avoid these blunders in OPD for our patients. So first of all, when the patient walks in the OPD, always confirm the identity of the patient. So always, even if the assistant has brought the patient in and he's sitting or she's sitting in the on the chair unit, I always ask, or we should always ask that your name is so and so. Just reconfirm that the same name patient is there, because sometimes it may happen that you are seeing some other patient and you are entering the data in some other patient, and that causes a lot of issues to the patient. So always make sure the first thing you do is identify the patient. In Western countries, wherever I visited, I have found that in fact the doctors also introduce themselves to the patient. Here in India, the practice is not so common because we assume that the patient knows whom he is showing, or because we already declared it outside that he will be showing to Dr. XYZ or ABC. But that is also a good practice to follow. If you have a habit, that is a good habit. Then always take brief history of complaints as you examine. So ask about what is his occupation, because many times that gives you a lot of hints about what diseases the patient may have, and at the same time what practical issues the patient might be having based on his occupation. For example, patient has cataract, but patient says that I am a teacher. So what do you understand by that? Can anybody guess? Just let it be interactive, so we also learn by different responses. So Prasanna, for example, patient has cataract sitting on your ophthalmic chair, and then you ask him what is your occupation, and he says I am a teacher. So what things come to your mind, and how does it different from maybe another patient who might be a
allergic reaction to the.
Hello?
Hello, sorry, I'm in the lift, so
Should I repeat the question?
yeah, please.
Sorry, I couldn't hear.
Can you please repeat?
Yeah, I will repeat. Am I audible now?
Yeah. The issue is not my network.
Second. Hey, Swara, मला हे पाहिजे, इयरफोन दे, हेडफोन दे. ऐकू येत नाही. Okay, am I audible now?
Yeah, yes.
Okay, so the question basically was,
1 second. Yeah. So patient has come, and patient has, you have already like seen the patient has got cataract, decrease of vision, and you ask him about the occupation, and patient says I am a teacher by occupation. So what are the different practical aspects that come into picture, as against maybe a patient says that I am a clerk? Hello, yeah, audible, you are audible.
Yeah. Actually, again, I was with a bad network, so I
Okay, okay. Somebody else can answer, maybe Dr. Sneha.
Yes, sir. Good evening, sir. So,
Yeah.
I would definitely find out what is the requirement of the patient. If he's a teacher, what for him, his near vision, his intermediate vision, and also the distant vision would be, what would be his preference, and accordingly advise the IOL to be selected. Also find out if he has any chalk powder allergy or anything like that.
Yes. So we have to positively ask for the occupation. So that is the, so what I, definitely ask patient, suppose patient is a teacher. So, they get vacations only in winter and, summer vacation and Diwali time vacation. So most of them are keen to get operated during that time. So, many times they come, say, 2 months prior to Diwali. And mainly they are concerned that whether they can wait till Diwali or not. Just giving a practical, way. Of course, that vision requirement is very important, as you said. And these are the practical things then we can think about. So the moment you start asking occupation to each and every patient that is visiting you, the practical difficulties patient might be facing. For example, patient has, say, corneal ulcer, but patient is, say, daily wage laborer. So obviously they have different, problems associated with their occupation. Similarly, and first thing, history of complaints you have to take yourself from the optometrist. Many times I get this complaint that optometrist didn't ask about this, or even optometrists miss out many history, or sometimes patient do not want to give all the history to the assistants. So make sure that you always take a brief history of the complaints before you begin. Many times patients do not disclose about their systemic diseases to optometrists. So the optometrists are there just for your, help. It is just the starting point that optometrists have already seen and spoken with the patient and given some history about the patient complaints and other things. But that is just a starting point for you. You are the person who is in charge of the patient and you have to be thorough with the history taking. Okay. So very simple example. For example, when you have a patient, young female, and you want to prescribe, a drug to that patient, what history you should ask the patient? Yes, anyone? Sachin?
If she is expecting a child or something.
Yeah.
If she
So
is
that is very
expecting-
important, whenever any drug you give to the patient, whenever any oral drug you are going to give to patient, always ask whether the patient is allergic or known allergic to any drugs or not. Okay. And second thing, if it's a married girl and in the childbearing age group, just ask her whether there is any other systemic issues or where medicines are avoided, or are you pregnant or any other thing. So these are very important things, because there have been medical legal complaints because of this issue, because we generally don't ask these questions, and then if patient is allergic to particular thing and you have prescribed him the same, and patients may not be aware at that time because he was not asked. He feels that this drug is for eye purpose, treatment of eye, so systemically it will not affect, something like that. So just make sure that you have taken all good history, particularly, as I said, main complaints, occupation, systemic diseases and allergies, and pregnancy. Anyone else want to add anything as the initial part of the treat this thing checkup? Okay, we'll go ahead.
So especially if
Yes.
the patient is on any psychiatric drugs or
Yes. Okay.
retroviral disease or something, usually they don't tell the assistants.
Correct,
And
yes.
only when you dig into the matter, you get to know that they have something like that.
Yes, that is also very true. Yes. Many times patients on psychiatric medication, you get a vibe that, they are not all right. So always ask, relatives also, like asking the patient to go out. Maybe they will give better history also about the patient. Correct. Yes. Any other?
Some systemic drugs like anticoagulants and those also can be asked at this
Yes,
point of.
yes. So for a
And
patient requires any surgery, then it's better that you ask. So usually when you are seeing a patient, I think you have to make it a habit, to keep examining the patient, and at the same time keep asking the questions, relevant question to the patient. That makes it quick examination plus history taking. That is how we take exam in we take cases in exam also. No, we have to finish in 10 minutes, 15 minutes. So that habit is very useful. So generally, when you make a habit that you are going to ask, certain questions in that order, it becomes a habit. And then by the time you are examining the patient, you tend to, continue to ask question and get the right answers. Okay. Now, the second thing is, what should be the first instrument to be used in OPD? Okay. So this, I think I have told previously also to my fellows and also other consultants. I think retinoscope or distant direct ophthalmoscope has to be the first thing. Whenever the patient sits, just ask the patient to look straight ahead and use this. Sachin, why do you use retinoscope or distant direct ophthalmoscope?
To see the red glow, sir, whether the patient has a good red glow, any media opacities. Okay.
Yes. So don't start examining the patient directly on the slit lamp. First, check the cross examination. Okay. And check the media, because see, as an ophthalmologist, we are mainly concerned about media. Any media haze is there, which might be because of corneal or lens problem or vitreous or retina problem. Okay. So that is something which is more of surgical, and we are interested in that primarily. Correct. So we have to rule out that first. If media is clear, you immediately know that you are not dealing with certain issues, like the cataract is not there, corneal problem is not there, vitreous hemorrhage is unlikely, and maybe retina may be normal. So similar to that. So one of the common mistakes which I have seen is that either the cataract is underdiagnosed or overdiagnosed if only slit lamp is used. Okay. So what happens is that if you don't look at the red glow properly and you directly see the patient on slit lamp, sometimes you feel there is a cataract, but it may be a normal lens. And other way around also, sometimes there is a cataract, like for example, PSC. And even today, every month, at least 1 or 2 cases of PSC are missed by, the optometrists or even consultants. That is because if they don't do the retinoscopy. Okay. And these, for example, there was one patient who maybe a couple of months back, she came, she was already advised cataract surgery elsewhere. Right. And then consultant saw the patient's vision was okay, 6x6 parts or something like that. And when these consultant told that, okay, you can use glasses, spectacles, and that's fine. Then the patient told the consultant that, no, but the previous doctor had told me that there is a cataract. Okay. So now the patient was little disappointed that maybe there was cataract and the doctor didn't show. So then she took second opinion and showed to another consultant, and there was a PSC. Okay. So now just think from the patient's point of view that if you miss this finding, which was already diagnosed by a previous consultant, then a patient obviously feels that this doctor is not good enough to examine. Am I right? Okay, so this is a very common thing, and that's why we have to always ask again. If patient was asked properly about the chief complaints, patient would have told about the problems of vision issues or other things when she was being examined. And of course, if you just do retinoscopy, these things can be easily picked up. Many times patients have cortical cataracts, and because they are used to driving at night, they are more bothered even if patient's vision might be good. Okay, so patient's vision may not be the criteria to operate. It's patient symptoms regarding the cataract which are very important to be looked into. Anybody else has any other experiences regarding missing or overdiagnosing cataract?
So while planning a refractive surgery, this is the most important thing. If you're planning something like press beyond or something, and early PSCC is missed out, and I have seen something like this happen, that's fine.
Very good. Yeah, that is very important. And at that age, even another thing which is overdiagnosed is blue dot cataract. So many young patients may be having refractive errors. If you see on slit lamp, you will find that there are blue dots or dot like cataracts are there, and so blue dot cataract never progresses. So the patient can still undergo refractive procedure. And other way around, as you rightly mentioned, if patient has PSC or cortical cataract, then no point in doing a refractive procedure for that patient. Another thing is nebular corneal opacity. Many times on, you do retinoscopy, you find there is a opacity, you feel that it's a cataract, but it's corneal opacity. So we have faced similar patient some time back when patient was diagnosed to have cataract, and then first it was seen by optometrist, then referred to consultant. Consultant also wrote that it's a cataract, and on table I realized that it's only a corneal opacity and there is no cataract. So luckily patient had refractive error, so after surgery patient was okay. But I think that patient had issues with the corneal opacity still. That means whatever the complaints patient had little bit, they were remaining, but then we had to counsel the patient accordingly. Okay. So this is the list of signs which are commonly missed. That is because you are not thorough in examination. So how many of you look at the endothelium when you look at any patient, when patient comes for cataract surgery or for any other thing? How many of you see regularly?
I see it regularly.
Okay. Prasanna is cornea specialist, so he will see.
Concentrating.
But yeah, that is very important because see, many times this is a very important sign, and it can be picked up on slit lamp if you properly see. So when you check the patient maybe having a cataract on slit lamp, you are not looking for exactly for the cataract, but you have to look for other signs, like as I said, the gatte are there or not, pigment dispersion is there or not, are there any nebular corneal opacities, because patient, the IL muster or topography may show say it's 4 diopter cylinder, but patient has a nebular corneal opacity. Now you have to be sure that it's a regular astigmatism or irregular astigmatism. So it's very important to not to miss these opacities. Yeah, before taking the patient on anything, RAPD. Now, most our optometrists are trained to look for the pupillary reflexes before they dilate or before they show to you. But you also see yourself. This is very important for mature cataract, because in mature cataract, if there is no RAPD, you are sure that patient is going to have improvement in vision after the surgery. But if there is a RAPD, you are doubtful that patient may not improve, and that way it becomes much easier to counsel the patient for that. Okay. Also, when you are looking through the slit lamp, look for pupillary issues, which are many times missed. For example, you have cataract, but is there a non-dilating pupil? Is there a presence of PXF? Is the pupil atrophic or cynic? Many times these findings are missing when you are looking at the patient, and then on table you realize that it's a non-dilating pupil, and now you have to change your plan of surgery. Then meibomian gland disease is commonly missed. If you find that, see, one of the common mistakes is that when you find MGD and patient has come for cataract surgery, the patient's primary, I will come to that later also. So you have to treat the primary complaints also, apart from treating whatever you diagnose. Okay. Then these I told already. Of course, pterygium. Many times what happens, the patient comes with the idea that when you diagnose the patient as cataract, patient has pterygium, but many times it is not mentioned in the examination finding, because you might have overlooked that there is a early pterygium or pingacula or something like that, and patient is under this idea that doctor has advised the surgery, so with that surgery my pterygium is also going to go, so the eye will become exactly absolutely normal. So that we have to inform the patient that there is little bit of pterygium, whether it has to be removed or not, that you can explain to the patient, but mention it in the examination finding and do observe if there is any such issue. Then of course other issues like zonular weakness is there or not. Now I find sometimes the consultant has seen the patient and there is subluxation or possible subluxation, or say for example patient has a iridofungal coloboma. Now these things should be properly mentioned, and it is important to assess the patient preoperatively and plan the surgery accordingly. Okay, I will give you an example. Recently, a patient was posted for me. Patient had microcornea, microphthalmos, iridofundal coloboma, and almost brown cataract. Okay, and patient had vision of 6/36. Okay, should I operate this kind of patient? Yes, Renu? See, microcornea, microphthalmos, iridofundal coloboma, grade 4 cataract, vision is 6/36.
So first we should evaluate for the posterior segments before operating for the cataracts.
Yes, okay. So patient has iridofundal coloboma. Posteriorly also same thing is seen. And patient is one-eyed. Other eye is already even smaller eye, even micro ophthalmos and no vision. So it is very important to understand the patient point of view. See, patient has come to you because he might have felt little bit of decrease of vision. Patient still has 6/36 vision, which is quite good, or ambulatory vision, with which he can easily live. Now, if we operate on a patient with microphthalmos, microcornea, and hard grade cataract, it is not possible to put any lens in that patient. We are also endangering the retina also. So you have to be also practical and understand the entire issue of the cataract, entire patient, like Dr. Sneha had sent me the message also. You have to, similarly, as we say that, look at the patient as a whole. Similarly, you have to look at the eye also as a whole. Because we might be treating cataract, but we might be inducing many other complications in patient's eyes. So we have to be very, very, careful in diagnosing, and at the same time, we have to be prepared for planning, like how we want to do this surgery on table. This is particularly useful for complex cases. Okay. Yeah. So there might be some complex cases which may require, some other specialty consultants help also. So in that case, for example, suppose me and Dr. Prasanna are going to do a case together where uh, Prasanna is going to do something for the cornea and I am going to do something for the retina. Then we have to pre-plan, like these are the steps which we are going to, take in order to not having any issues during the surgery. So it's very important. Okay, then always in the history also, sometimes patient themselves mention that this eye I had low vision since childhood. So that you have to mention. Many times this is not mentioned because if there is a amblyopia, most of the other things are normal. Even sometimes biometry may be normal, minor squints are missed. But if you look, you question the patient properly and patient gives this kind of history, you should always keep in mind that there is a possibility of amblyopia and you should mention it. Okay, any other thing anyone wants to add? Just it's an interactive session, so anyone can add to the discussion. Okay.
Sir, just I want to say that many patients have cataract with pterygium.
Yes.
And so I have experienced one patient, someone have advised him for pterygium excision. I operated the patient and patient came post-operatively to me and he said like how it is. So I said it's okay and you can go for cataract surgery. Then he was asking me why the lens was not put. So I think the patient was not properly consulted that it was a pterygium surgery and not a cataract surgery.
Yes.
So he was repeatedly asking me why the lens was not put at the time of operation.
Correct.
So, but yeah, so before just I want to say that before like pterygium excision, patient should explain about the pterygium excision followed by the cataract surgery. Like
yes. So who is responsible for this explanation?
So I think the consultant who is advising should also explain, and the counseling also, sir, like the counseling also should like both should like counsel the patient that it is not for the vision, it's just to prevent like post-operatively need for spectacle. So we have to operate the pterygium surgery. So it's I think both for the consultant and the counselor, sir.
Yes, perfect. So that is the importance of counseling in the OPD. Many times what happens, where we have multiple consultants in centers. Okay, so one consultant assumes he has written the advice form, so it will be explained by the counselor. Okay, now counselor assumes that the surgeon must have explained most of the things to the patient, so maybe needs to just give a date. And then operating surgeon is a third person who may not have made the patient before. Okay, Bhushan, I think you have to mute your. Yeah. So then the issue comes. Okay, that's why whoever is the primary ophthalmologist of that patient should try to counsel the patient thoroughly that this is the plan of action which I am going to give it to you. Of course, there might be sometimes issues that patients still do not understand, but at least consultant should counsel the patient properly why we are taking this decision of removing pterygium first, and then we are planning to do cataract later. And also the counselor should also again re-emphasize on this point. This avoids these issues. Okay, so same thing applies to other specialties also. Okay, so whatever patient comes to you first, you are like the primary ophthalmologist for that patient. So you have to try to explain to them thoroughly that these are the options, and even if we are like, for example, I am going to, send the patient for, say, glaucoma opinion or for cornea opinion to someone else. I should emphasize this issue that, see, you have this retinal problem as well, which we'll see. But first, I feel there is also a corneal problem for which I need opinion of the cornea consultant first, and then we'll decide what to do. Okay, so this is the best approach to avoid any confusion for the patient. I will also tell you what you need to do when you are tackling the patients. I will just continue now. Okay, so first of all is listen to the patient. And this is many times missing. Like, understand complete details of the patient complaint. Don't ask the patient to stop initially. Just let him talk, let him or her talk about the complaints. Because many times, for example, patient has come for, say, patient has cataract, but patient is complaining of other things like I have watering, maybe I have diplopia, something like that. So whatever patient's chief complaints are, you have to first look thoroughly for finding out reason for those complaints. Now, if reasons for those complaints are found out, then you are sure that after this particular treatment, patient will be relieved. Okay. So, example given, there was a patient who came for cataract surgery, but he was advised cataract surgery somewhere else. But when he came to me, I asked him what was his complaints. So his complaint was not decrease of vision, though he was already told somewhere else that cataract surgery is needed and patient had significant cataract. Patient and complaints of watering. Okay, so now what I am supposed to do is I have to first check why there is a watering. So then what most of the consultants do is that they will not bother about asking the patient. You see a, even advanced cataract or something, you advise the patient cataract surgery. So what I should do in such cases, I should do, if required, syringing, check if there is a block, NLD block or something, or if there is any other cause of watering. Now, this patient had bilateral common canalicular block. Now, then I have explained the patient that, see, there is a watering, this complaint will still remain, though we can operate for that also. Results may not be very encouraging. Now you have got significant cataracts. We can undergo cataract surgery now. If you are still bothered about the watering, we can try a procedure later if you feel, but it may not give you a very like 100% results. So based on that, when we decided to go ahead with the cataract surgery. So now the patient is pre-placed that even after cataract surgery, this watering is going to continue, which I have explained very emphasizingly to the patient. So that is very important. Otherwise, this patient will come to now Dr. Renu post-op visit, and patient will say ki watering to kami nahi hua, right? So that is the problem if the primary doctor doesn't explain properly about the complaints, whatever all complaints patient has, whether that will be taken care of not. For example, some patient complain of floaters also. So they complain of floaters, but they have also other thing like maybe pterygium or cataract. So they have to be explained that this is not, floaters are not going to be treated by this particular procedure, what we are doing. And the purpose of this procedure is this, something like that. Always go through old reports. So many times they give a lot of, additional information, which is very important. Sometimes patient also don't remember what was, done to them, or what surgery was done, or what injection was given, but they have many times forgotten. For example, I had one patient who had cataract. Asked him whether any procedure was done earlier or not, or laser was done. He said nothing was done. Maybe some laser I remember was done and all. Then when I went through patient's old records, he was already operated once for retina surgery. There was bleeding and everything, and again laser was also done, and anti-VEGFs were also given. But this patient had almost forgotten many things. So it's very important to go through the records and always take time. Patient, in fact, appreciate if you go through old records very thoroughly, even if you understand or not. Many times they have got systemic checkup records and all, lot of things are done. Even if you don't understand them completely, it's better, it's very useful if you in front of them just see, go through all the pages, and that makes patient is also assured that doctor is very much, diligent and taking care that he goes through all the record. Okay, and any relevant old reports patient has, patient might have got scanning done somewhere else, or some critical diagnostic test was done. Always ask your assistant to get it attached to the EMR, because it's very useful for our patient management later. So I think very important to listen to the patient's primary complaint. And believe me, many times patients are unhappy because you have not understood the patient's primary complaint when the patient comes to you. Okay, so the same thing again, addressing the chief complaints is the foremost priority. Okay, so it is very common blunder to get excited by seeing some other signs. Okay, for example, I am a retina specialist, so I get ekdam excited. There is an old BRVO there, and I should laser it or maybe do some other thing. And actually, the patient's complaint may be some irrelevant. Okay, to that whatever you have found out, or a cornea surgeon finds out there are few gatte, and the patient may need some procedure later on. So starts explaining about that procedure rather than focusing the patient's at that time main problem, which may be MGD, or patient may have dry eyes. So just understand, don't get excited by seeing some other signs which patient may not be understanding. You might have seen it and you feel that now patient has got this disease also, but it may be completely irrelevant to patient's chief complaint. So the first focus should always be patient's chief complaints. Believe me, still this is one of the common blunders done by us consultants. You have to go in patient's shoes and understand what the patient has come for, and that is something which we have to prioritize to treat. Simple thing, for example, not giving painkillers. I have seen that patient has come for some reason, maybe corneal aberration or some corneal ulcer or something. All other medications are given, but painkillers are not given. Now patient's chief complaints were pain, so we have to reduce the pain first. Okay, so that is very important thing. Any other experiences, Bhushan, you have, or Prasanna, Deya madam? All of you are experienced, so you must have had some experiences that you think of, Josna.
Yeah, one
Bhavin is
patient had
there.
come for squint surgery, sir.
Yeah.
So I had 24-year-old man, but with 0.9 cupping. So I told him ki, you're correct, squint surgery is must. I counseled him only about squint surgery, but I told him ki you have to be under continuous follow-up. Now say if I bombard him with glaucoma, vision chala jayega, aisa he'll get more and more confused. So first I got the squint surgery done. After 1 month he was very receptive. So then I got him got perimetry done for, of course, for medical to be legally safe. I done one OCT pre-op, optic nerve and pressure documentation. But I did not tell him much about it because he was more keen for squint surgery because usko shadi karne ka tha. So now after 1 month, now he's got everything done and he's under close follow-up also. So as you rightly said, we have to address patients' concerns first, but we have to be intelligent enough to kind of see the whole eye as a like the whole picture. ये आगे कैसे करना है? Yeah.
Correct. Yeah. Yes. Anyone else wants to share? Okay. So we'll go to the next. This is another blunder that I have seen being done. In fact, even I have had this issue that we feel that we know everything about ophthalmology, but sometimes we don't know even have knowledge of available treatment option. So I remember one of my fellow, so he was seeing general OPD, and at that time I think we were running some campaign for squint. So squint surgery, there was some advertisement was going on, so we used to have good number of squint patients. Okay, now whenever, and we found that the patients are coming, but nobody is getting ready for surgery. So then I found out that this fellow had the idea that if patient has cosmetic squint, Then after surgery, patient also again develops squint. Okay, so that was his general idea about squint. So that means he had no knowledge about treatment of squint. 70-80% of squint surgeries are basically done on cosmetic squint only. Like for example, patient has amblyopia or other things, or sensory amblyopia or sensory problem. That's why patient has squint. And out of those, only 5 to 10% have recurrence of squint. 80 to 90% are doing well. So this fellow had no knowledge about it. He didn't bother to discuss it with squint specialist, and was telling the patient that even if you operate, it will again recur after a year or so. So this clearly shows that that fellow doesn't have knowledge about available treatment option. For example, now Dr. Prasanna sir or Seema and Renuda, now they can do corneal tattooing. But if patient with a dark corneal scar, blind eye comes to you, and a patient, sometimes patient also do not know that there are these treatments which exist. But a young 25-year-old a girl or a boy, now they have issues with cosmesis, like if they have a white cornea in one eye, we know that they also are looking for cosmetic options. So you should be knowledgeable about the treatment options, like there may be cosmetic contact lens, tattooing, or for thiatrical eyes, we can do motility implants after evisceration. So all these treatment options should be in your knowledge. So if you don't know it, it's very easy. We have WhatsApp group of consultants where you can easily put your questions, and you will get multiple answers, even more than which primarily, and you will get many options which you can tell to the patient. Okay, so even if we have done our MS, DOMS or DNB, and maybe we are working as a fellow, or maybe working as a consultant, we must make sure that we refresh our knowledge time and again, because definitely eyes cannot see what brain doesn't know. Recently, a simple a 20-year-old boy I saw, he was advised spectacles by a consultant. Okay, and by chance the patient's parent, because he was showing me since quite young age, they insisted that no, we want to show to him only before he goes back. So because he is staying somewhere else in other state or something like that. Okay, so I checked the patient's previous glasses given 2 years back showed -1 cylinder, and today when he was checked, patient had a -2.5 cylinder. Now this is very interesting. Why in 2 years patient's cylinder suddenly increased? Okay, while the keratometry which was done with the autoref was showing 43 and 47, something like that, 45 and 47 keratometry. So I asked the patient, no, I feel there is some issue. Let's find out if there is something more. So I did the pentacam and OCT, and the patient had keratoconus in the eye. Okay, so simply the consultant here, I would definitely say the consultant who had seen this patient has failed miserably in examining this patient properly. Okay, because you have all the signs there. You have the old history of refraction done on this patient. The keratometry, which was primarily done, was showing 47 plus keratometry. And you have the spectacles also, which are now changed, and cylinder had changed. So we have to be very careful. And this is definitely because of lack of knowledge or lack of observation skills, that the consultant didn't see or check the proper, whether there was any change in the spectacles, and just advise the patient spectacles and come back after a year. Okay, so this is very important, to be very observant in the OPD. Don't be casual. Even if patient has come for refraction, patient may be having some other issues. That's why patient has come to show you. Okay, so there are many other treatment options also, like we are doing amblyopia management, the vision therapy is there. There are many therapies for improving convergence, other problems like asthenopia. Then many times we have other options for treating refractive errors also, like for clear lens extraction is there. Many patients are bothered by early cataractous changes, like presbyopic age group patients, where we may ask the patient or give the option of presbyond or other refractive procedure to the patient. Then for corneal tattooing, I already mentioned, there are many other cosmetic procedures also we can do. Many times patients come with some lid swelling, baggy, eyes or something like that. They can also be offered many other options. There are problems like conjunctivochalasis, medial lid ectropion, which causes watering to the patient. Many times we miss these findings, and we know there are simpler surgical methods to correct these problems. So can be done by the specialist. So always, whenever you feel whatever patient complaints you are seeing, you are not able to explain that, of course, take help of other consultants who are specialists in that particular field, or post in the group. Somebody will be able to answer it better. Okay. Any other thing anyone wants to add about their specialty, or something which was missed by other consultants should not be missed? Because many times we come across these issues. Yes, Josna, anything about glaucoma or yeah.
If it comes to glaucoma, I had recently seen two interesting cases. The first one was in Belgaum itself. This was a drug-induced glaucoma that I had seen. The only catch for me to diagnose that it was a drug-induced glaucoma, acute glaucoma, was the history. So history plays such an important role, and this was caused by antacids basically. Patient had some flu and he was on antibiotics along with antacids, and he developed a myopic shift of -5, and also his pressures rose to 60 within 2 days of taking ranitidine. And
Okay.
I think the only history only could lead me to this part, because myopic shift was definitely showing me that it was a drug-induced glaucoma. So the moment we dropped off the antacid, we got to we came to a conclusion, because he reverted back to zero plano power again.
Yeah, very well. This another issue. Like recently, I think, in fact, we had to pay back the patient. One of the I think fellows saw the young patient, maybe around 30-35 age group, and patient complained that suddenly, since 2 days, his vision has deteriorated, and on autoref there was, I think, -2 or -3 refractive error. Optometrist also did the refraction. The fellow saw the patient and asked the patient history. Patient categorically said, even the optometrist has mentioned, sudden diminution of vision in just 2 days. Okay. Now, at this point, the fellow didn't, even look for other causes. Why there should be suddenly change in the refractive error? Okay. What could be the causes? It can be very high blood sugar level. It can be, like you said, if there was AC shallowing or something, maybe drug induced. Okay. That was not even looked for. And patient was prescribed glasses. And what was the reason for his sudden change in glasses? He had sugar levels of 500. So he had sudden rise in hyper sugar level, because he was from outside Sangli, and he had come here to meet his maybe, I think, wife's family or something like that, and they had sweet dishes and all, and he ate a lot of sweet dishes, and probably he was already a diabetic or borderline diabetic, which he had no symptoms of, and because of eating sweet dishes, I think blood sugar suddenly rose to 500, and that caused refractive error. Okay. So he is when he of course his wife's family was an old patient of our hospital. So after this, because he had other issues also, like giddiness was there and other things were there, they went to a family physician also, who checked for blood sugar, and it was found that it was 400, 500. Okay. So now he came back after a week saying that now with spectacles he is having difficulty, though he has made it. He is not very happy with the spectacles. Now we checked the refraction, it had come down, not to 0, but it was still say -0.75 or something. And then we realized that patient had high sugar level. So based on history, definitely we made this mistake that we didn't ask for proper history. We didn't listened to the complaints of the patient properly and missed this finding. Okay, so this is very important about history taking, speaking with the patient. And of course, patient had the same question: why didn't the doctor ask me if there was sudden change in number, when even now you are saying that it can be because of high sugar? Why it was not asked to me, and I had to spend so much money for the spectacle, which was correct on his part, right? Okay, so that was one of my experiences.
Actually, I think before prescribing glasses, if there is any hyperopic shift, we should make an SOP to do RBS even in the clinic right then before giving the glasses.
Yeah.
That's what I have been asking my optometrist in Belgaum, because
Yeah.
recently we also came across similar thing, but thankfully patient did not go for the prescription that
Yeah.
was given.
So whenever you feel that sudden shift of refraction is there in last, so we have to look for the diabetes also. I initially told about the keratoconus progression also. So there has to be something which we are missing in that case. Okay.
Another point about history regarding taking medicines. I think patient is always the right person to tell which medicine is working better for him. This comes especially with anti-glaucoma medications. We might feel one medication is good for him, and as per book, we would go with prostaglandin analogs. Again, one more patient. This was a juvenile open-angle glaucoma, or it could be a pigment dispersion glaucoma that was query. So this patient was given prostaglandin analogs, and patient already had maybe counting finger vision. Pressures rose from 40 to 60 after adding PG analogs. So the
Okay.
patient himself, within 2 days, he comes back and he says, my vision has deteriorated with these medications. And I think that is where we have to pay attention. Later on, this patient got operated last week at Kolhapur. So I think a patient was insisted to take prostaglandin analogs despite the history, because
Yes.
we all feel PG analogs are the best for glaucoma to bring down the pressures. But then if it is pseudoexfoliative glaucoma or pigment dispersion, in those cases, I think these medications can actually worsen the glaucoma.
Yeah. Another thing is understanding the allergic symptoms also. Like for example, brimonidine-induced allergic blepharoconjunctivitis is a common thing and sometimes missed. And we keep treating the patient for some other reason. And even if we stop brimonidine, the symptoms will reverse, right? That is something which I have seen. In fact, I have seen one patient who had simple brimonidine-induced allergic blepharoconjunctivitis, which the primary treating ophthalmologist simply missed. And then he asked the patient to keep continuing that drop for a very long time and added more anti-glaucoma medication. Added then over that some other medications, some low dose steroids and other thing, and ultimately patient landed up with medicamentosa. So entire cornea became hazy. So simple thing like brimonidine allergy was missed, and patient had to suffer a lot because of that.
Yes, sir. I was reminded of 3 more things with this allergy part.
Yeah.
Any periocular allergy that we come across in patients who have these eczematous eyelids and periocular itching, there are 3 things I have noticed. If it's females, some of them, they tend to have allergy to vermilion, that kumkum they apply. So once we tell them to stop using kumkum and then go for bindi stickers, they are very well, they do well with that, with a little bit of steroid treatment. And some of them, they are in the habit of using hair dyes, which they get allergic to after using for a chronic period of time. And then drug induced. So these are the 3 things we have to rule out. And especially retired people or people who are more into spiritual things, they tend to pluck flowers in the morning, and unknowingly they tend to rub their eyes. Maybe that also can cause some kind of allergy, periocular allergy. So I have I have frequently seen these 3 things as the causes for periocular contact dermatitis.
Yeah, contact dermatitis is one thing. So mucus fishing syndrome and contact dermatitis, these are also commonly missed. Like patient has a habit of, trying to fish out mucus from nasal part, and they keep on having this redness of eyes, and the only treatment is asking the patient not to touch the eyes, and it cures them completely. Okay, so we'll move on. So another important thing which is commonly missed is taking clinical photos. I think the clinical photos are very important for counseling, for teaching as well, and clinical as well as medical legal purpose. I think I have emphasized this on our group many times, but this is very important for any student, fellow, and consultant, that make sure that whenever you are seeing a patient and there is something which needs to be documented, make sure that you document it properly. Okay, because otherwise what happens is that later we cannot properly tell the patient or counsel the patient what was the problem and how it was earlier and how it is now. So it is very important that make sure you have some kind of, even if you don't have access to probably maybe a photo slit lamp, then take a gross photo with camera. So any gross photo is even better than no photo at all. And we have EMR where we can easily attach it to the crystal EMR and easily see it later. So anything which you feel that it has to be documented, make sure that you document it well and show to the patient. It's a very good counseling tool. Patients immediately get counseled once they see, like say corneal ulcer is there, or trauma, after trauma there are some hyphema or other things, or if there is early, many times what happens, patient comes to us and we diagnose the cataract first time, and patient may not, we immediately look at their face and we realize that they are not ready to believe that they have issue, or their relative is not ready to believe that they have some issue with the cataract. In such case, if we take retroillumination images on maybe a autoref or on slit lamp, then immediately they will come to know, yes, the whatever doctor is saying is right. So this is my common practice, that I show the patient that, see, this is the cataract. About the surgery or what when to do, that we'll discuss it later. Okay. So I think this is very important. Make sure that you keep proper clinical, or sorry, the photos or data of the patients for the patient counseling part. Okay, so I think this is very important to understand the patient psychology in the OPD. So there are different types of patients who come to us. Some have come for treatment which is already advised somewhere else, and so they are willing to undergo investigations required immediately. So they come that I am already diagnosed as cataract or maybe glaucoma or some other thing, but I want to get treated here only. So we have come. So that is one set of patients. So they are ready for any investigation and for treatment also. Now some have come as just they want second opinion. They don't want to get any investigation done or anything, but they just want to know whether the treatment is required or not, and whether it is urgent or not, or if there are any alternatives. So you have to understand that this is their main purpose. And then there are some new patients with minimal complaints, but you have diagnosed them with a new disease, for example, glaucoma. So these are the patients who will require extensive counseling, explanation, and reassurance that this is, many times what the commonest mistake what I have seen is that patient is diagnosed glaucoma, but nothing is told about how the prognosis is, how we are going to treat it, and the doctor has not even reassured that don't worry, even if you have glaucoma, you are not going to become blind. Okay, so that is one of the very, very common. The diagnosis of glaucoma is done very casual way, without understanding patient psychology behind this problem. Okay, so I think glaucoma specialists can tell better, because we also make these mistakes. But so whenever you label a patient that patient has glaucoma or glaucoma suspect, you should be able to justify. The commonest blunder what I have seen is that patient has physiological cupping, or sometimes patient has thicker cornea, so ocular hypertension, and consultant has diagnosed the patient as glaucoma. Now just think from patient's point of view, glaucoma is a potentially blinding disease, and you have diagnosed the patient to have glaucoma when patient actually doesn't have glaucoma at all. Okay, any thoughts about this, Josna, Sneha? I think you will be able to tell more about glaucoma.
Yes, so most of the times this happens. If just one pressure on NCT if it is more patient is started on anti-glaucoma treatment without investigating the patient or without knowing what is the reason behind it. Most of the times, even post-operative patients, because of the steroids that they are using, they can have this transient rise, but nothing is done and directly the patient has started on anti-glaucoma. That should be, first the cause should be found out and then the treatment should be started.
Yes. And most
Hi,
importantly,
sir.
yeah. Okay.
When I see a patient of glaucoma, and like I have seen the patient in the OPD, and the patient has the first reading of eye pressure, and that is on the higher side. I tell the patient that okay, you are a suspect for glaucoma, but glaucoma is not just one thing. It is not just about high pressure. Yes, majority of the glaucomas do come with high pressure, but we also need to check your optic now. We also need to do some tests to confirm whether these changes are because of glaucoma. So once you explain a little bit to the patient, then they realize that okay, this is not glaucoma. Just one reading is not indicative of glaucoma.
Yes, very, very, very. I think this is one of the most misdiagnosed thing. That is what I feel. And sometimes we are also little confused because, for example, some case scenarios like, very high myopes or, post retinal surgery or something, and maybe very bad retina also, where we just have to rely on maybe IOP. So in such cases, what is the protocol, Josna, Sneha?
Sir, again, investigations, seeing the CCT, doing IOP on applanation tonometry and seeing the fundus and perimetry findings and all that, a triad of all of this, if it corresponds and if you only then you start the treatment, patient on glaucoma treatments.
Yeah, that is true. But sometimes like in myopes, pathological myopia or perimetry and even OCT doesn't work. So any guidelines for that, or we should not treat, or we should treat based on IOP only? I think there are basically some patients who are definitely glaucomatous patients, and there are some patients who are definitely not having glaucoma, and then few remain in that borderline zone where there is always a doubt whether we have to treat or not treat or observe and how to observe. Okay, I think that can be referred to the patient, the specialist. Okay, any other in case of this thing glaucoma, any other mistakes that commonly encounter?
So most of the times patient is started on anti-glaucoma by someone else who has seen the patient outside. And then once you tell them that they don't have glaucoma and you have to stop the drugs, that is also a very difficult situation to treat with, because the patient thinks that you are not advising the right thing to them. And maybe someone else who has seen him outside, they have told him he's been diagnosed with glaucoma and you want to stop the anti-glaucoma. This is also a very tricky situation to handle actually.
Yeah, that is also depends on patient's personality. So sometimes patients are very happy that doesn't have glaucoma, so they will immediately stop. And sometimes you have to wean them off the anti-glaucoma. Like I had one patient who was on 4 drugs and had no glaucoma. So over a period of a year, I slowly reduced all the drugs to still the patient is not ready to stop one medication. He wants to continue that one medication. That is true. Okay. So that was about glaucoma. Yeah, this is another important thing, which is very important. And I think I have emphasized it again and again to all. Never inform the patient through the assistants that, your test is normal or abnormal or whatever. Always call the patient or relatives, discuss the investigation report, what they have paid for, and inform them these are the next steps which they have to undergo. So this kind of creates miscommunication, or many times what happens when we are seeing, say, these patients every day in and out, we are seeing so many patients and we are getting these scans done. So we are used to, normal and abnormal, these words, but patients are not aware of reports, what they are supposed to see or what they are supposed to, interpret from these reports. So it is very important to ask the patient and speak to patients and the relatives face to face. Show them if there are anything particular thing you want to show. For example, patient has, say, macular edema. Ankush, so do you show the patient that, see, this is the edema which you are seeing, or these are the problems you are having in the retina? How do you go about showing the reports to the patient?
Hello. Yes, sir. I generally tell the patient to see the OCT and let them know that what is the normal and how the edema is looking like.
Yeah, so that is very important. Even same thing about even glaucoma suspect. If you have a patient whose disc looks suspicious, of course, in Sangli we have IDON, and I think we'll get non-midretic camera elsewhere also. But you have access to imaging devices where you can actually take a photograph of disc. You immediately know when you see the patient that patient is not, really sure that what you are saying is right or not, or you advise him glaucoma test, but he is not sure, why it was advised. So what I do, I generally ask my assistant to again check the IOP in front of me. I again, show them the disc photo. See, this is the disc photo, which shows that, this white part or the cup is very large. And I will show them another patient, in the same list, some other patient's photograph where you can see that the disc looks normal. So that is the difference. So that way you must counsel the patient. Even when you do glaucoma workup, and suppose it turns out to be normal, again you have to explain to the patient, see, these are the two tests we have done and they appear to be normal, so we'll just keep a close watch. It's not yet normal or abnormal. Okay. And for retina, so everything is based on images, so it's very easy to show them that these are the issues that they are having and this requires this kind of treatment. For example, diabetic retinopathy, also you have fundus photos where you can zoom in and show them, like, see, there are blood spots there, these are the issues, these are the diabetic retinopathy. It really helps in counseling. Any other ways to counsel patients? Any reports
Well, I
show
feel
to?
that most often the perimetry and the OCT ONH are the two reports which are very less frequently explained to the patient,
Correct.
because the test itself is done in another room and the patient just comes with the reports and we just say, okay, you start these
Yeah.
drops. So I generally, what I do is I tell the patients that, okay, this is a scan of your nerve, and usually both the eyes are on the same page, so you can tell them that this is the right eye, this is the left eye. And I usually, the RNFL is quite color coded, that the optic nerve RNFL in different sections. So I tell them that this is a color coded graphical representation. Whatever you are seeing in green is normal, whatever is in yellow is borderline, but whatever is in red, it suggests that there may be some damage to the nerve because of glaucoma. And then I tell them the perimetry. I tell them, okay, you can see these dark black spots in this image. So these are the points where you did not respond correctly. You were not able to see the light which was given to you and you did not press the buzzer. So in your visual field, these are the points you are not able to see well. So then probably the patient gets an idea that, okay, there is some damage which is there because of the glaucoma, and then you can tell them that, okay, we will start these drops, etc.
Yes, I think that's very useful. That's very important. I think next time I will definitely show, because we don't realize that patient do not understand these reports, and we assume that patient knows that these are green is normal and red is abnormal. That's a good point to tell
Yeah,
to the
in my
patient.
experience also here in Pune, because they have lots of multiple options for cross reference. Whenever I explain in such a way, same as Bhavin, patients automatically like are compliant with medicines also and follow-ups also, and they are very happy when we explain. Just takes a minute, but it's a very good.
Yeah, very important point. Thank you. So
Sir,
next,
sir, even in for OCT
yeah.
also, if the patient need a second injection, if we tell them and compare the OCT and ask them to, like, they will also understand. The understanding will be much better that they will definitely need a second injection like that.
Yes, yes.
So
Retina to all is about imaging only. We treat
yes,
images only. We don't treat patients sometimes.
yes,
So imaging has to be explained to the patient that this is how it is. Yes, perfect. Okay. Okay. So another thing, in many times what happens is that we have a lot of optometrists. Most of them are here for help. But I think we have to understand that we are the persons who are responsible for patients' perfect care, though they are there to help us in the work, but then we are ultimately responsible. So even for optical prescription, you check what was written by the, optometrist many times, because we may not always cross check, but whenever there is a doubt, you recheck. I recheck occasionally whenever I feel there is a doubt. Many times optometrist makes mistake in plus and minus signs also. For example, previous prescription, that patient was wearing +2, and this time the optometrist has done -2. So you immediately know it's a typing error. So many such mistakes can be avoided once you go through. Another very important thing is that consultant must understand, though we keep training our optometrists every now and then about what are the guidelines. Like recently we had an issue, like a child was given refractive error of 0.5 cylinder or something like that, 0.75 cylinder. Now there are American Academy guidelines which state that for each age group, what is the, up to what level of refractive error you need to give, or after how much of refractive error you need to give, and up to which you need, the child will not read glasses. So the ophthalmologist should also be aware of refractions and rules of refraction, definitely, which is very important, because ultimately, though patient has come, for refraction, and it may be the optometrist, primary responsibility, you are there to, check, cross check, and you should understand the importance of cycloplegic refraction also. Like the patient has, or the child has come 12 years old, the child is diagnosed to have myopia. It's very important that first time you are prescribing glasses, then it has to be done only after cycloplegic refraction. So there are many important basic rules which you need to follow. You should know. So whatever optometrists know, you should always know. It is not so that, you don't know anything about refraction. That is wrong, because patient understand you as the principal caretaker of your eyes, of their eyes. So if they have any doubt about optometry also, they are going to ask you. So update your knowledge about refraction. Do not forget how to do refraction. Now, you want to do refractive surgery tomorrow. Are you good in doing refraction of the patient today? That you have to make sure. So always make efforts to do good refraction in the OPD. Don't forget about doing refraction. It is true not just for cataract surgeon. It is important for cornea surgeons as well as retina surgeons, that they should be able to do good refraction for the patient afterwards. Of course, nowadays we have got very good optometrists to help us out. But if you have good knowledge about refraction, then it really helps in OPD. Okay, I have had patients after retina surgery, patients were not given good glasses, and that's why they had poor vision. Patient were all operated somewhere else. And when patient came to me, I did a good subjective refraction and the patient was very happy. So many times outcome is by doing a good refraction. Same is true about trifocals also, and even refractive procedures also. Afterwards, after trifocal implantation, patient requires refraction, you should be very good at doing, perfect refraction and give it to the patient. It may also, you may think about treating that afterwards by doing refractive procedure later, but you should be good at doing the primary refraction. Okay, so never forget doing good refraction, good retinoscopy in patient. If you are not doing that, at least do one patient refraction now. Because I know that many times, unfortunately nowadays, in post graduation also, refraction is not properly taught or not done, and then fellowship, so you don't even touch the trial set. So you may forget, or you don't know how to do refraction. So if you are keen to do refractive procedures also in future, you should be 100% perfect in doing refraction for the patient. Okay, now this may sound harsh, but I feel that sometimes you are forgetting that you are ophthalmologist. Very commonly, I have seen that many consultants or fellows are not able to diagnose general ophthalmology problems. For example, lead lesions, they are confused what to do. NLD problems, like patient has discharge, whether there is a common canalucular block or monocanalucular block, or if there is a NLD block, they are not able to diagnose. Neuro problems, you can't do a proper confrontation test also. Many simply patient comes with cataract, patient gives a history that they had hemiparesis. If patient has significant cataract, may not undergo perimetry, you should be able to do confrontation test, because maybe he has lost half his field, and that is why he is complaining of vision loss, while cataract may be just a early cataract, may not be having any issues with vision because of that cataract. So you should be able to diagnose those simple problems yourself. Many times if there is a disc problem, it is either missed or you are not able to diagnose it what exactly it is. So you should learn about optic nerve lesions, what are the DDs of differential diagnosis of disc edema, and these are things which are easy to forget when you are in practice. You have not seen a disc edema patient for last 6 months, and patient comes to you, you have forgotten about all the DDs of disc edema. So you have to continuously upgrade yourself, and keep on reading also about these issues, because you are primarily ophthalmologist. It is not that you are a specialist and you look only for this. You should be able to diagnose other specialty problems also. You may not be doing surgeries in that specialty, but definitely you have to be able to diagnose most of the thing. And if you can't diagnose, don't just refer that patient to specialist and just forget about the patient. Remember, you are the primary care physician, so just make sure that you are in touch with that patient. You ask the other consultant if he has seen the patient and what she or he feels that this can be this diagnosis or that diagnosis. So that definitely will upgrade you. Okay, I have seen that mediocrity has definitely seeped in last few years. Postgraduate training is very poor. So basis or fundamentals are very not very good. But that does not mean that you should not keep learning. Now in our hospital or our group of hospital, we have so many good specialists and good consultants who are masters in their field. So it's always important that you should keep learning about ophthalmology and various advances which are there all around. Don't keep be mediocre just because maybe you didn't have that much of exposure during post graduation or later on. Make sure that you are a master or a specialist in at least diagnosing various specialties in that matter. Okay, so that was one of the things which is harsh reality. I wanted to tell you. I will not go to any ophthalmologist who is not thorough with diagnosing about any other specialties for that matter. At least attempt should be made by that ophthalmologist to diagnose what it is. So always keep curiosity going on, like what can be wrong with that patient. Take help of the specialist, but try to diagnose. Okay, now the next part is about writing surgical and medical advice. You have to be very, very, very thorough about doing that, because I have seen many times you have examined the patient, you have done everything, but while writing the surgical or medical advice, you are very casual and you miss things. Like for example, simple thing, and we have all written formats of writing surgical advice. It has form, it requires you to fill up many other things. Like for example, many times the prognosis is not written, the OCT reports are not properly filled, the cataract, what cataract first, what which right eye, left eye, whether it is early cataract, requires immediately or not, or patient has some other problems, like for example non-dilating pupil, or patient has systemic problems. Nothing is explained seen properly. And when you advise about lenses, you have made circle on all lenses, like monofocal, trifocal, multifocal, toric, LRI, everything. How can you advise all 100 lenses to the patient? You have to choose between 2 or 3 options, like whether if patient is good for either extended depth, or patient is good for trifocal. So our patient can be good for LRI, or patient can go for toric. You cannot have multiple choice questions. Same way for refractive procedure, you have written patient can undergo PRK also, LASIK also, and other things also, and IPCL also, and this thing also. Now you cannot advise multiple things. You have to prioritize. Like if patient is okay, let him go for say SMILE, or let him go for femtolasic. Or if patient does not want to opt for this costly option, patient can go for this particular option. So you cannot tick on everything, then that makes counselor also confused, and that is basically not a good advice, because you have to prioritize that these are the things which have to be explained to the patient. So be thorough. If there is a doubt, you can always ask your colleagues. If there is a doubt about writing medical advice also, you discuss and write then properly on the advice form. Okay, then these are some other issues which happen in OPD. Like for example, we are not happy with the OPD management or coordinators. That is absolutely fine. But practically, why do you want to share it with patients that I'm not happy with this, coordinators are doing this issue and all? Patient don't care actually if mistake is yours or any of your staff members or team members. Basically, it is always our mistake. When the patient has come to see me and patient is not satisfied, irrespective of OPD mismanagement, patient can be satisfied if the consultant apologizes and does the needful. Whatever is needed or whatever apologies are required, if we do that, it solves most of the issues and can be solved. Then the incidents can be reported and we can get a preventive corrective action done. That is a sign of a professional or a mature consultant. Many times, if you start the sharing problems with the OPD management with the patient gets the idea that this is not a good managed hospital and better I should not come to this consultant at all. So better, it is important that you do whatever is needful at that moment, and later we can always sort out these issues once we have a meeting. Okay, another sign of professional behavior in the OPD is that there has to be personal attention to end-to-end patient care. Okay, whenever I advise something, we have advised this particular test, make sure that it is done and it is shown to you after that, and make sure that patient can go through the test as early as possible. Don't just give it to your OPD coordinator and forget about what it is being done. So whenever you are asking the patient before sending to counselor or other consultant, always tell the patient, if you have any doubt, I am here. You just come to me and ask me any question. I will be here to help you. That is a way professionally we should refer the patient to counselor or anyone else. Don't, many times patient come and ask, sir, but what to do next? Don't say, now go to the counselor, he will explain. No, say to him that I have written what is the best, solutions for you. My counselor will help you or explain you everything. If there is any doubt with that matter, you can always come back and visit me and ask me any question that you want. Okay, this is way to deal when you are sending the patient. Even when you are referring to, say, you are a retina person and you want to refer to glaucoma patient, glaucoma consultant, you should always tell that I'm referring you to the glaucoma specialist. Let him or her check whether what is the problem with you, and then if you have any doubt, you just meet me, so we'll decide what to do. Okay, so whenever you are leaving the OPD or taking break or going to OT, make sure if you are checking if the patients are waiting there for you or not. Many times we hurriedly go to OT and we forget that there are patients, and your surgeries may last for 2-3 hours and the patients are harassed because of that. Okay, make sure that if there are any waiting patients, just finish them and then go for break or go whenever you are leaving OPD. Okay, this is sometimes which is very important. Do you need to be repeatedly called by coordinators for after extended lunch break time? That is not professional. There are patients who are waiting for you. You have to be courteous enough to be there on time so that patient do not waste time. Otherwise, we get very bad feedbacks about our system that doctors do not respect the time, etc. Okay, it is very important when you are working in a team or when you are working in a group, whatever we give, we get back. So if we show good respect to the staff, which might be OPD coordinators, secretaries, receptionists, or even security or admins, fellow consultants, students, and patients, then we get respected. So we have to make sure that we show utmost respect to each and every team member as well as to the patients, giving a very personal, attentive care. That is when you are respected back. Okay, so these were some of the points about OPD blunders, which we have to make sure that we avoid as far as possible. Okay, any other points you would like to add all of you are senior consultants. There are many points which you might come across in the OPD which might have caused issues for patient care, your own patients or somebody else's patient. You can think about it. I will ask one by one. If you have any other, experience, Nikunj, you can share.
There can be some issues in dilatations and pilocarpine.
Yes,
So
yes, yes.
how to handle those?
Yeah. So here, yeah, Nikunj, I think who asked actually?
Yeah. So, sir, no blunder as such, but I think we should listen to optometrist and ophthalmic assistant as well, because few of times I have, they have helped me in neuro-ophthalmic cases, diagnosing in neuro-ophthalmic cases. Vision is 6/6 or 6/6 part. You see everything is normal, media is clear, retina is okay. But then your optom will tell you that sir वो VH पढ़ रहा था, LNA नहीं पढ़ रहा था, या LNA पढ़ रहा था, VH नहीं पढ़ रहा था. In 6/9 also he was doing same. And then if you do perimetry, and many of time I think I have diagnosed it 3 times, ICSOL मिल जाता है या फिर stroke का case मिल जाता है. One of the time I had checked out the patient, optom had checked out the patient. Rupesh, our ophthalmic assistant, he told me कि sir वो आधे letters पढ़ रहा था, because they observe you, since 2 years. So they know कि आप क्या diagnose करते हो, क्या नहीं करते हो. Then I called up patient back and then I checked the vision. So yeah, he was missing half of the letters and he had stroke. So it's important to listen to them as well. So
perfect. Yeah. Very good point. I think there was one more question regarding dilatation, na? Somebody asked.
Yeah. Or pilocarpine.
Nidhi. So I think we are giving bands to patients, na? Wristbands to patient who require pilocarpine.
Yes. Just only thing is if it has been followed in all the centers. And also dilatation, the charts, if it is being maintained in all the centers, because there have been complaints in centers where patients were put drops multiple times and there was no follow-up how many drops were put. So I hope it is being done in all the centers.
Actually, I heard one experience not from our hospital, but another retina surgeon's hospital. So the patient had come in the morning at 10 o'clock to him, and patient was advised dilating drops. And he was waiting there for his turn, and dilating drops were put. And nobody asked the patient why he is there. And patient was also maybe very introvert, so he also didn't ask. So at 4 o'clock, one of his, OPD coordinators saw that this patient is staying, sitting there, and then asked the patient, like, why are you sitting here? So patient said that I was asked to put drops, so I think they were put, and then I'm waiting for my turn. For 6 hours, that patient was just sitting in that. And by the time patient was seen again, the dilatation effect had gone already. So again, he had to be put dilating drops. But, that shows, because there was no charting, nothing, nobody was, looking after like who are the patients who are dilated and after how much time they have to be seen again. These are the issues that may happen. So I think that has to be followed in all the centers, that you have a dilatation chart. And now patient knows, sometimes I've seen that the assistant may in one patient put only 2 times. In some patient, they are putting 5-6 times. That should not happen. If they have a chart in hand, they know exactly at what time, 1, 2 or 3 third drop is put. And after that, say after 10-20 minutes, patient has to be taken for a examination. So nowadays patients are very clear. They have gone to other, hospitals also. They know that these drops need not be put, these many times, or, not just one time and taken, something like that. So you have to make sure that the assistant also know how to put drops properly. Also, while putting drop, they have to explain to the patient what are the side effects. They may have trouble in driving back, or the near vision will reduce or something like that. Yes. Any other? I think pilocarpine and tropicamide issue is there. For example, patient is waiting for YAG iridotomy, and patient is put tropicamide. This I think is a blunder which we have seen sometimes. So this putting the wristband for those patients who have to be put only pilocarpine helps, because then everybody knows that these are the patients where we should not be putting any other drop, just pilocarpine. I have seen once without chart a patient who was waiting for yak PI, and the assistant thought that the pupil is not dilating. The assistant was new, and she was putting pilocarpine and thinking that pupil will dilate, and it was not dilating. So she put the pilocarpine almost 10 times, and patient actually had symptoms like OPC poisoning because of so many pilocarpine drops were put. Okay, so these things, to avoid these things, I think chart for putting medication, topical medication is very important. Yes, Prasanna, any other thing?
Making it a point to talk to the patient before taking up the patient on the operation table can also sort out multiple problems in our cases, because in our centers the advising surgeon is someone advising doctor is someone different, and operating surgeon is someone different. So we can make it clear exactly what procedure the patient can expect is going to happen with him.
Yes. So it's very important. That's why everyone has to contribute, whenever, of course, this will happen more and more when you are a specialist and others are seeing patients for you, something like that. Or suppose I'm going to operate on retina, but, my colleague is seeing the retina patient, or, I am seeing the patient for him and then supposed to operate. So yeah, it's a good idea to see the patient before surgery yourself. So you have better idea, what exactly you are going to do. Yes.
Another thing that I just wanted to make a point that many times we see patients who are only having refractive error. Okay, so just a routine consultation, patient has a refractive error. I think it makes sense to spend some time with the patient discussing what type of glass that they should be using, or what are the different options, and where they may find some particular type of glass better than the other. Like many times patients are just struggling with progressives because they have never been told properly how to use a progressive, or how the power distribution is done in a glass in a progressive, where the power is mainly in the center part. So you should not try moving your eyes left and right to see, and you'll see weird things. So simple things like bifocals, don't wear it when you are climbing down a staircase, because the floor may appear uneven to you. So for every patient, like when I am seeing a patient in the OPD, once history is done and you are started examining, and roughly what the patient is having, so then the mind is actually started thinking that, okay, what I'm going to talk with the patient. So for every patient, I think that little 2-minute talk what we have to plan. So if a patient is a child and having refractive error, then maybe you should talk a little bit about whether there is amblyopia, whether patching is to be done, or what parents can expect, that the number may increase, may not increase, or good habits or good postures for reading for children, something little different. But for every patient you can plan something where you can talk a little bit about that problem, so that kind of builds a good rapport with the patient.
Perfect. Yeah, I think fantastic. That is, in fact, every alternate day, at least I get one patient, because they get the spectacle made here only, and they have trouble in adaptation. Of course, my optometrists are very well trained how to, train the patients how to use the progressive, but because many times these patients have made expensive specs, so they want to meet. So yeah, that is one of the things which I have to do is, train them how to use the progressive. Even you should know little bit about fitting of the specs also. I think Bhavin, you have rightly, like I had one patient just a week back, made very good specs with Zeiss progressive, etc., and was not happy. And what I found out that the frame which he was wearing had no pantoscopic tilt at all. and that was the reason. So the moment we corrected that, he was extremely happy with the spectacle. So similarly, I think decentered glasses, if they are not properly, centration was not done on the frame with the IPD measurement, etc. All this troubleshooting, I think I have one more lecture on spectacle troubleshooting. Maybe next time we can take that. It's very useful. And as you rightly said, when you have a patient who has come just for refractive error, I think it's a good point to tell them. Like many times I tell them that go for a progressive glasses or photochromic glasses. Many here are agricultural workers, so they are immensely helped by the photochromic glasses. Then desktop users are for progressive specs. Many patients are concerned about whether they should use acrylic or plastic glasses, or they should use glass, something like that. So these all things, it's very important if you speak with them. That's a very good point, Bhavin. Thank you.
And another thing is patients nowadays, we get a lot of patients who are young and who have this digital eye strain or computer vision syndrome. So they're also probably just 2 minutes, because there's not much to examine. Most of the
Correct, yeah.
examination is normal. You just have to spend those 2 minutes so that the patient feels that okay, he has come with a problem and you have tried to explain something about that problem.
Yeah, I think nowadays Seema is there in the IT hub of Pune. So I am sure that she is seeing many of these patients having computer vision syndrome and dry eyes. Okay, Ankush, anything you would like to add? Dhanraj has recently joined us as consultant, so I'm sure he is having some consultants issues now. Dhanraj, any issues that you have faced, OPD?
Hello, am I
Yeah,
audible, sir?
Dhanraj. Yeah, audible. Yeah.
Yes, sir. There are many people who are coming with most of the dry eye patients and all, and that too with the computer vision syndrome also. So yes, we used to just keep on explaining about their sitting arrangement, as well as they're supposed to not to face the AC, as well as to just blink, as well as that. I used to keep on explaining the 2020 rules to all of them.
Yes, it is very important, these routine OPD patient. Many times, I think Bhavin rightly pointed out that we feel that, they just need specs. What else to, speak with them? But I think many times when we are in the OPD, or our basic mindset or basic interest is in operating. Like I have to, find out patients who need surgery. But as somebody has, told me when I joined, a practice management consultant, that you have to be able to supply, smaller orders first, then only you will get big orders. That is what Amazon started doing, supplying small orders first, and now they are into, big business. So that is how it is. So even patients who are not for surgery, we should be able to spend good enough time. That's a nice point, Bhavin. Okay. Josna madam, Sneha madam,
Yes.
would like to add?
I have a point to add, sir.
Yeah.
Whenever a patient comes and walks into the OPD, we also have another potential patient with them. It's the attender always. So I always look at the attender once I am done with the patient. If it's glaucoma, it's very valid because we have to always screen the family members of a glaucoma person. And this got me into the habit of doing it with every patient, even though it is a non-glaucoma patient. So even if a cataract patient walks in and there's the attender sitting there with a pterygium staring in his eye, so I make sure that I also make the attender sit on the patient's chair once the patient is done examining. So I tell him, you have a pterygium and I would like to have a look. And I do this for free because I want him to be willing for surgery. So once I don't insist on getting a card for him or paying the consultation fees for that. So I just tell, see, there's a pterygium and you can yourself look into the mirror. Then he tells me, yes, I know that there is a growth in the eye. And then I tell them, "See, since you have come for this surgery, we'll finish with this. And meanwhile, you can plan for the other surgery whenever you come for the follow-up." By then, his mind is prepared and he comes with the mentality of getting his operation done. This also
very true, very true. It's a good point. And as you said, glaucoma, family
Yes.
history, even diabetics, familial. So yeah,
And
in glaucoma, many
especially-
times we miss that. Yeah.
Yes, sir. This I do for every glaucoma and even non-glaucoma. Especially if the parents are coming, maybe with a small kid or something. The kid may be very irritable in the hospital atmosphere, but still I make sure that I take a retino or a distant direct and just look at the glow for the kids, even though they are not our patients. But then the mother or father would have come for a presbyopic glasses. I feel okay. I feel it's my responsibility to do so, and also the patient has this okay, the patient is concerned for the entire family. The doctor is concerned for the entire family. And sometimes we do pick up a dull glow in kids, and they might be pre-verbal kids with a high refractive error, which gives us a suspicion. Then I call them on a weekend, like this kid needs a CTC. So you have to take time. And when it comes to kids patients, they never tend to postpone or anything. They drop everything and they come the immediate next day. They don't even wait for the weekend. So
Very good points. Yes.
Attender,
In
I
fact,
look at them as
that
a
reminds me. Yeah, that reminds me. There was one patient, I think a lady, and she had glaucoma. Okay, and she had some other issues also, systemic problems, and she used to visit me, and every time her husband used to come with her. Now, and so of course, husband, so not a relative, that's a blood relative. So after 2 years, he came for his own checkup with the wife, and he had moderate to advanced glaucoma. Can you believe? So wife had glaucoma, quite advanced, and he was coming with her for so many times to me, but I never, asked him that get your eyes also checked, because he was also old. So I think that is something we tend to miss. We just focus on the patient and don't focus on the attendant. Yeah, very good point. Yes. Many times actually with glaucoma patient, their brothers or sisters have come. So I think that point has to be told to the, and I tend to do, but as you rightly point, we have to make sure that it's a habit, then only we don't forget while in a busy OPD. Very good point. Yes, Dr. Sneha.
So the medicines that the patient uses, the boxes and this thing also, I personally check them because they interchange most of the times and they use it whichever way they want. So that one point I check. And also about the crystal entries, the reception staff, in finding the names and all that, if it is wrongly written, then it's difficult to search. It's not like a blunder or something, but
yeah, many times I think those two good points. Even post-operative medicines, in fact, I think posted on the group today. Make sure that it is properly understood by the patients and they have all the medicine in the kit. So I think my fellows or students are here, they must have seen that when I come to see post-op patient, I make sure that I open their medicine pouch and I make sure everything is labeled properly and given to them. Otherwise, we had this issue recently where patient was operated and patient had medicines, but somehow the patient didn't buy the medicine. Patient was given prescription or something like that. Post-op day also bandage was removed. Patient was not explained about medicine. They assumed, everyone like consultant assumed that it is there with the patient. And when patient came for 3-4 days for follow-up, and then the consultant added more drops. Okay, so and those were written by the OPD coordinator, again assuming that patient already has those initial drops. So for a week, patient was not putting any medication. So that can happen because see, many times what happens that though it is a OT coordinator's responsibility, if they make a mistake, then who is to suffer? The patient has to suffer, and patient will always blame that consultant didn't tell me, because ideally we should be there explaining each and every patient that these are the medicine, this is the OT coordinators are there to help us out. So I think make sure that everyone knows that these are the things are there with them, and particularly for specialty surgeries, because cataract, I think even the staff is very well aware, and the medicines explained are very easy. But for refractive procedures, for corneal procedures, for retina, I think the operating surgeon himself should better, it's himself or herself, should better check with the relative or patient that all the medicines are there with them and properly labeled and inform them. This is very sometimes becomes very problematic if patient is also literate and he understands that it was mistake of the from the doctor's point of view. Yeah, even I think one of the things is that always meet your patient post-operatively at least once, telling them that everything was good, or whatever, we will see you again tomorrow or something like that. That helps. Okay, and anything else? Komal, you had new experiences as a consultant from OPD? Hello? Yeah.
Same thing, sir. One more thing, in allergic conjunctivitis also, we should, these kids come with, they come frequently with the symptoms of allergic conjunctivitis. We should always advise them about avoidance of the allergens also. Like how much ever possible it is, but we should advise them about avoidance of allergens also.
Even I think another thing about allergic, if we are giving even low dose steroids or something, always make sure that you check IOP on every visit. Because whenever patient is on steroid or even low dose steroid, sometimes patient may have IOP spike. So make it a point that IOP is measured each and every visit.
About allergic conjunctivitis, I often also advise the parents that this whatever low dose steroid we have given, that this is to be given only after eye doctor has seen and not by themselves, because because it happens so frequently that parents tend to use it on their own. They may use irregularly, once a day, twice a day, but often it happens.
Correct. In fact, when you give PRED, you have to 100 times tell them that never use it, more than whatever I have given. Otherwise, they will always feel that this is the best drop and they will keep putting those. Yes.
Yes, sir. Just 2 days back, I saw one patient, young patient, 20-year-old. He has developed PSC in both the eyes. He was using steroids for almost 1 year. He himself knows about it, and he tells that I used the drop for 1 year, and I have developed cataract in both the eyes now.
I operated similarly one young boy, bilateral cataract and bilateral almost near total cupping because of steroid induced glaucoma. So they don't understand sometimes. Yeah. Okay, so it was a good discussion. Thank you for contributing. Anything else anybody would like to add? Nidhi, that I have to explain it. Okay, thank you. Any other additions you would like to add? Just put it on the group. It's always a learning experience. Like I learned so many things, Josna, about the attendance. We have to explain about spectacles also. We have to add, and all other points also. Yes. Okay. Can we end the meeting now?
Yes.
Okay. Chalo. Good night, everyone. Bye.
Good night, sir.
Good night, sir.
Good night.
Good night, sir.